Okay. Can you all hear me at the back? Shout yes. Thank you. That's great. The theme is basic, and we all have our different definitions and uptake on the word basic. But I'm going to introduce one that perhaps may sound as a surprise to you. Basic definitely means, do you know your anatomy? And more importantly, do you know the anatomy with the imaging modality that you actually try and image it with, knowing the strengths and limitations of that modality? Those are, without question, the two fundamentals that underlie the basic knowledge. But there's a third, and the theme today with this particular talk is, do you know the basic pathology that underlies the diseases that we're talking about, i.e. infection and inflammatory conditions? So the approach is going to be very much on the pathological processes and how we need to know this so that we can make the right pathological diagnosis using the imaging modalities that are available to us. And if we start with something that we all learned very, very early on when we were in medical school, which is the cardinal signs of inflammation, whether it's infective or otherwise, these are the 5 clinical cardinal signs. And you've got them on the left: heat, redness, tenderness, and swelling, and this will result in some degree of functional physiological loss. But the pathology on the right is also very important. And the reason why I start with this is because we have the sophistication because of our basic knowledge, and it doesn't matter whether you use plain films or MRI, you have to know the basic pathology of what is going on to produce heat, i.e. hyperemia, what is going on to produce redness, which is also hyperemia. The tenderness and the swelling is due to a mixture of fluid within the tissues, exudate, as well as hyperemia. And then, of course, all of these result in some physiological impairment. The hyperemia and the exudate is something that you're going to see the effects of, as well as seeing it by imaging itself. And put simply, there are 3 things. You're going to see soft tissue swelling with fluid. You're going to see the effects on bone, which is either loss of bone or else a proliferative effect due to the hyperemia as well in having new bone formation. So the approach is very much on 3 anatomical sites, the target sites of whether the infection or inflammation affects bone, whether it affects the synovium within the joint or tendon sheet, producing synovitis, and whether it actually targets the enthesis. And for all those who need to be reminded, the enthesis is the junctional point where the ligament and tendon joins the bone. So we start off with bone infection. Now, the infective organism can reach bone in various ways. The most common, without question, is hematogenous spread, but there are other sites. You can get any bone that's infected due to direct implantation, for example, surgery or a fracture or an open wound. But remember, you can also have soft tissue infection first, which slowly spreads towards the bone as well. But by far, the bone infection that we're going to be talking about is the one produced by hematogenous spread. And there are usual suspects here. And when I say usual, I mean that if you're talking about pyogenic, well over 90% of bone infections will be due to the same organism, i.e. Staph aureus. And this can be incredibly aggressive. You heard yesterday in Conrad Verstraeter's wonderful talk that the definition of aggressive also applies to non-malignant tumors. So in infections, they can also be very aggressive and it can be very worrying when you look at them on imaging. And then there is the more indolent, low-grade type of infection, which is caused by granulomatous processes, classically tuberculosis. But both these conditions, in fact, every organism that infects bone, will produce an osteomyelitis. And it's really the osteomyelitis that we're going to address. And what we're talking about here is the infection is taking place within the medullary cavity of bone primarily. That's where it starts, and that's where it spreads from. And the words come from the ancient Greek. Osteon is bone, and myelonos is marrow. So what's happening? Firstly, you will get the marrow which is going to be the site where the infection actually starts, and very quickly the marrow is replaced. There's no normal marrow here at all. This is all pus and pus cells, which has replaced the entire marrow space. And then secondly, you get bone destruction. There's no bone here. All the process has been producing a lot of osteolysis. And then after a while, the bone reacts and produces some sclerosis. So the pathology is going to be edema and release of fat, which we'll see some examples because the cells in the marrow are destroyed. Clearly, you're not going to see that on plain film. But on plain film, what you see is bone destruction and sclerosis. So what are we talking about? Just a quick example. This is a patient who has an infection within his distal femoral epiphysis. You can identify with one imaging modality the site of osteolysis. You can also identify some osteosclerosis around it, so you can identify the bony response to osteomyelitis. What, of course, MR shows you very nicely in this fat-suppressed image is that the normal marrow is suppressed, whereas the edematous marrow involving the whole of the epiphysis now shows you the myelitis component. So both are seen and both are important in assessing the degree of bone change. Now, what is also crucial in the basic knowledge is that some modalities are better suited in one stage of the disease and not so good at other stages. So in the acute stage, the plain film can be completely normal, and yet in the chronic stage, the plain film can be more useful. Why? Because there are three stages. There's the acute, the subacute, and the chronic components of osteomyelitis. I'm going to spend some time in this diagram explaining it, because once you understand this, then it's very easy to understand the radiology that follows. The focus almost invariably starts at the metaphyseal end. Why? Because there's a lot of arterial arcades there. It supplies the growing end, so that's why you have a lot of arteries. But more importantly, they are end arteries, meaning that any bacteria passing through the bloodstream are likely to be blocked at that stage, and they will take hold and root and therefore cause an infective focus. The infective focus will immediately destroy marrow and destroy bone around it and form an abscess. And then the pressure builds up, and it's so high that the pus has to find its way out. It can only do so by spreading down the shaft, but more importantly, it goes sideways, penetrates the endosteum, penetrates the cortex, and then finds the space between the periosteum and the cortex, and it spreads down the shaft. And in doing so, it can strip the blood supply of a large area of the marrow bone, and it can also strip the blood supply of the cortical bone, producing bone death. So when you look at this histology slide, you can see there's bone here. There's still some cells telling you that the bone is alive, but notice the whole marrow space is completely replaced. So what is the definition of acute osteomyelitis? It is the definition where the infection is there within a few days and up to maximum 10 days of it having been implanted. And the signs are therefore going to be predominantly myelitis. The bone marrow is going to show a lot of changes. The cortex will start to become ill-defined, and then once the pus goes between the cortex and the periosteum and it's elevated, the periosteum will form some new bone formation, and not surprisingly, because it's such an inflamed state of affairs, the neighboring soft tissues will also react by becoming edematous, and therefore you lose the definition of the soft tissue planes with generalized soft tissue swelling. So here's a nice example comparing, in the early phase, the bone and the MR. The bone will show you diffuse osteolytic appearance, but nothing really specific, except that if you look at the cortex, it is definitely thinned out on either side. It's only when you look at the MR that you'll notice that the normal marrow pattern on T1, which is what you can see on the talus, is now completely replaced by an extremely edematous, and I repeat, aggressive process with a lot of soft tissue swelling around it. Now, what is the definition of a periosteal reaction? We use this loosely, But we need to be sure that we understand what we mean by that pathologically. Number one, it is a purely reactive process. It doesn't specify what the underlying condition is. And in terms of infection, it is a reactivation of a periosteum that's there and dormant, and it's reactivated because it's elevated by the presence of pus. But more often than not, when we say there's a periosteal reaction, what we mean is there is new bone formation. That is what we mean by it. So to put the basic knowledge that we've discussed in context, I'm going to show you this case. This patient is very ill. He's got a very high fever, and yet his plain film of the area, which is swollen clinically and is very, very tender, looks, for all intents and purposes, as normal. And this is the MR showing you the normal marrow pattern on the contralateral side, asymptomatic, as compared with the osteomyelitis spreading from the metaphysis to the diaphysis, and also to a certain extent in the epiphysis. And also note why you have loss of soft tissue planes, because you've got a lot of swelling of the neighboring soft tissues. Periosteal reaction will develop with time, and the younger you are, the quicker it will develop. And usually in the younger age group, by 7 days, you tend to have a periosteal reaction. So the periosteum almost certainly was elevated at that time, but you couldn't see it forming new bone. It only forms later on. And can you see periosteum by MR? Yes, you can, because it is elevated by the presence of fluid, as we said on that diagram, between the cortex and the periosteum, and therefore it will also be seen as being elevated, but in a different way on a plain film. You only see it when it starts forming new bone formation. Now, we discussed fat release, and this is quite an interesting mechanism, which actually, when you understand it, is quite straightforward. When you look at the marrow of the distal femur here, you'll see it's got a high T1 signal, just like fat here, which means the largest component for that signal is, in fact, the fat within the marrow cells. And then when you compare it on the affected side, you'll see most of that signal is lost. What's happened to the fat? Most of the time, that fat is destroyed, not because it's destroyed itself, the fat cells are destroyed. And by that, we mean that the cell membrane ruptures, but where does the fat go? The fat will go in exactly the same way and the same path that the pus will take. It will try to escape. Some of it will remain in the medulla, and some of it will try and escape through the holes created in the cortex in a subperiosteal fashion. So on the T1, you'll see this wonderful stream of free fat globules here in a subperiosteal location. And on the fat-suppressed post-contrast, you see the areas of enhancement showing you where the osteomyelitis is, the soft tissue enhancement as well. And these are fat-suppressed areas of fat, loose fat that's been released from the marrow in a subperiosteal state. Infection can also involve the spine. And once again, it's no surprise that the infective focus will go towards the end of bone because of the same arterial arcade mechanism. Now, please remember that what we're talking about, almost 100%, is not an infective discitis, but an infective vertebritis, meaning the process is an osteomyelitis, which then slowly breaks into the disc, and then slowly with time, if allowed, goes into the neighboring vertebral body, and then soft tissue spread as well. So what are the signs as a basic knowledge? You need to know that the end plate appears white on X-ray and black on MR, on all sequences. So what you look for to help you decide whether there is infection is the site of commencement, i.e. you look at the end plate, and is there continuity or is there discontinuity to suggest on either of the techniques that there is, in fact, a problem. Please remember that this process is taking place before you see the disc changes. I'm going to show you an example that I hope will cement this concept in a basic knowledge way. This is a T1 of a patient who's got a high fever, a high white cell count, with a lot of back pain. The vertebral body signal at that level is abnormal. It's uniformly low on T1. And if you look closely at the superior end plate, you'll see it's indistinct anteriorly here, and the marrow's signal edema with that loss of end plate would suggest and should suggest that the patient has an infection. If you look at the T2, you'll confirm that the end plate is in fact lost here. But what this also shows you is there's a soft tissue process going anteriorly in the adjacent disc space. And if you look at the same process with intravenous gadolinium, you'll see that the contrast of the vertebral edematous marrow has now more or less equilibrated with the levels above, which are normal, and it shows you the area of infection spreading to the end plate destruction into the disc. So this is a very nice example to, I hope, make you accept that this is a vertebritis with secondary spread. Of course, the plain film, once the infection has spread, is very helpful because of the adage, when you have a vertebral body seemingly collapse with a bad disc, that's good news, which suggests that you are not dealing with tumor from the patient's perspective. But what you have to remember when you look at the plain film and you see disc space loss, end plate irregularity on either side, is that what you are seeing pathologically in those vertebral bodies is the infection reaching the end plate at the other end of the involved intervertebral disc to suggest that this is in fact active infection. And here's another example to identify that what catches your eye is loss of disc space, loss of end plate irregularity on the plain film, and paravertebral soft tissue swelling, which are all the basic signs that you should know to suggest that this is infection. And once again, what you identify on MR and you predict is happening on the plain film is extensive marrow replacement by an inflammatory process. So in a nutshell, the disc involvement is almost invariably secondary to the vertebral involvement and the loss of the end plate. But it can be very difficult sometimes. And here's such a case. If you look at this vertebral body, this is a patient who was sent to us from the metabolic unit, known patient with metabolic bone disease who has exacerbation of pain. And the clinician saw the film first and said, right, this patient now has a complication, which is a fracture from metabolic bone disease. But the problem is, it is not just a benign fracture. Why? Because the intervertebral disc is completely destroyed. And if I could just give you one take-home message, it is definitely this in the metabolic bone disease patients. Please always be aware that the figures are quite high, that 1% to 2% of patients who present with vertebral fractures actually have an infection as the cause of the vertebral collapse, not a benign etiology. And this is also important when you are interpreting your film, how easy it is initially to think that is one vertebral body which is fractured, as opposed to very severe bone loss of both vertebral bodies with a fluid here, which will, of course, mislead you if your interpretation is not right. So to counteract and avoid this problem is very simple. Never count the vertebral bodies anteriorly. Always count them by having the equivalent posterior arch, and therefore you will know that, in fact, you're dealing with two vertebral bodies rather than one which has collapsed. Sub-acute osteomyelitis is not an uncommon presentation in clinical practice. Sometimes this is referred to as Brodie's abscess. And in this situation, the bone has already reacted. The infection is spread in a serpiginous way, forming channels on bone, but you can see its delineation because of sclerosis. And the subacute phase is from about 10 days following the acute phase to less than 6 weeks of the infective process. And this is what you see. You see the serpiginous part that the infection has taken, destroying bone, but also the sclerosis that actually tries to contain the infective process. I've already shown you this picture earlier, but I'm showing it to you again because apart from the marrow edema and the area of bone destruction, please note that you also, after some time, have a penetration through the cartilaginous unossified component as well, and that can also go into the joint and cause a synovitis. Now, chronic osteomyelitis is the condition when the infection is left untended to beyond 6 weeks. And the hallmarks of this are the presence of sequestra, meaning pieces of dead bone, the presence of openings in the cortex, known as cloacae, and the periosteal new bone formation, which can be quite exuberant, that wraps itself around the infected part of the bone, the so-called involucrum. You can identify sequestrum on plain film, but you really, if you want to identify it more accurately, I think CT is unparalleled. And what you're looking for is densities of high CT signal surrounded by pus or in this case, fibrous proliferation around the sequestrum. And it can be small, and it can be very large as well. And I'm going to take you through this very recent case that we've had to highlight the progress between the acute, where you can't see anything on the plain film and the patient presented, to the subacute, and then the chronic phase, the chronic osteomyelitic phase. And you'll notice on this film that there is a bone within a bone appearance, and there are two well-defined lucences, one here and one there. And if you see those two lucences, to have clear lucences, the defect must involve the cortex. So they are more likely to be cloacae. And here's the MR of this patient showing you diffuse marrow replacement, virtually involving the whole of the diaphysis in reaching the bone ends. And there's the bone within a bone appearance that we've talked about. The soft tissues are edematous. And then when you look at the next images, you'll identify the cloacae, which is allowing the pus to go through the medullary cavity into the periosteal, subperiosteal space. And if you then compare the same appearances on MR with CT, you'll see this is a very large sequestrum, which is the reason for the bone within a bone appearance. This is the involucrum, and these are the cloacae that allows the pus to escape through. And it's important that you identify these features because operative intervention usually requires, at this stage, quite aggressive treatment with multiple channels and irrigation processes to try and remove the infection. It's incredibly difficult to do so once you've had dead bone. However, you also need to identify the process, and the infection here, as you can see, is spreading. This is why you get this large sequestrum formation, devitalizing the blood supply to that bone. But it also helps you to show you what is going through the cloacae. This is why MR is so helpful, because by definition, if you see edema and marrow and you think it's pus and a bone defect, then clearly you're obviously saying the same process has taken place and escaping through the bony cortex. And not surprisingly, the soft tissues can be edematous around the bone, but you can also have space occupation close toward the cloaca. Why? Because you have abscess formation and a very thick fibrous proliferation coat. And you can identify these in follow-up. There's the cloaca here, allowing the pus to go through, forming an abscess, and the thick fibrous proliferative coat overlying it, and another place here as well. The chronic phase in the spine is also important, but this is, of course, somewhat different in its implication because you have collapse, and that collapse can give rise to bone fragments, and the sequestra can therefore go inside the spinal canal and compress the epidural space, and it can also compress the cord. The abscesses also can form anteriorly and within the epidural space, causing neurological deficit. But in the same way, as we saw before, the vertebritis breaks the cortex and escapes, allows pus to escape in neighboring soft tissues. In this case, not only has it gone into the disc, but it's also gone into the neighboring psoas muscle, and you can see multiple pieces of bone here, multiple sequestra with abscess formation by migration into the psoas space, as well as the epidural space. Now, abscesses are important because, in a nice way, put simply, if you see an abscess, you know that there is active infection. The abscess can be local, close to the site of bone infection, but it can also spread. And when it spreads, it will do so across the anatomical planes. This is a patient who has a normal femur here, and notice this is grossly abnormal from chronic osteomyelitis. And in this case, he's had a recurrence of symptoms, lots of soft tissue swelling, and just note the massive, extensive abscess formation that is traveling down towards the knee. And post-contrast, you can identify the enhancement at the edge with the abscess in the middle. Epidural abscesses are also very important to identify. Sometimes they're localized. This is a post-contrast image showing you a posteriorly located abscess. But please remember, there is no barrier to stop that epidural abscess from spreading right up to the foramen magnum and all the way down to the sacrococcygeal region. You can easily identify it by doing axial images, of course, but the important thing is to identify abscesses, particularly in the spine, please use contrast-enhanced studies. And this is really important if you want to see where it's spread. This is a patient who has active infection at this level, probably at that level as well. But notice the value of contrast medium. If you go upwards from the area of abnormality, it's not very clear what's going on here, but it's very suspicious something's going on when you inject contrast, because you can see the membrane separating the theca posteriorly from the abscess going upwards and upwards and upwards, and all the way, can you see that? Going all the way up to the C2 level. So in any epidural abscess, please remember the whole spine needs to be investigated, and you cannot really assess it without injecting contrast medium. Psoas abscesses are not uncommon. They're usually much larger and much more common with tuberculosis, but more or less you have exactly the same pathology that we've discussed, first in the bone, spreading, destroying cortex, and then once it reaches the anatomical plane, then it can go wherever the anatomical plane directs it to go. Now, there is some confusion sometimes with chronic osteomyelitis when you hear the term Gary's osteomyelitis. And Gary's osteomyelitis is something that we certainly learned when I was a radiology trainee, and you can see what we're talking about, a diaphyseal area of a lot of osteitis, loss of the endosteal outline, and periosteal thickening as well. If you see that, I think it's important to ask the patient whether he has, in fact, had a history of osteomyelitis. And the reason is, more often than not, these days, it's generally recognized that we're not talking really about Gary's osteomyelitis, but another form of osteitis, which is called SAPHO, which is Synovitis, acne, pustulosis. That is the clinical entity, and then what we see radiologically is hyperostosis and osteitis. And if you see that, the best thing to do is a whole body, either scintigram or MR, because almost invariably you will see other sites, which could be quiescent. Now, the second part of the talk is going to be dealing with inflammation. And I'm targeting the synovium as my focus point. And the first thing to show you is what synovitis looks like pathologically. This is a large clump of synovium that has been removed arthroscopically by the surgeon. Please remember that when you look at this histologically, you cannot tell, the pathologist cannot say whether that synovial hypertrophy has been caused by a rheumatoid process, a psoriatic process, an infective process. It is not easy to say what it's likely to be due to. The basic radiology of synovitis is fluid formation in the joint. By this, we're talking about an effusion and synovial thickening. That synovial thickening, clearly you are not going to see on a plain film, but if you do an ultrasound scan, you are going to be able to differentiate the solid fronds of synovium from the fluid. And if you do an MR, particularly with contrast enhancement, you'll also see, obviously, the pathology, which is synovial thickening differentiated from the effusion. Now, a very special type of synovitis in chronic arthritic processes, particularly in rheumatoid, is pannus formation, and by this we mean really solid clumps of synovium which will cause an intra-articular space-occupying process and cause erosive disease. But the hyperemia that's associated to produce all of these changes will also increase the risk of erosive disease and also, with time, cause the bones to soften. But how do you detect, as a basic knowledge, an effusion on a plain film? So let's look at the MRI, because this always helps us in understanding things. This is a patient who's got a large anterior fat pad, which is normal in front of the distal femur, and a normal fat which sits above the patella. And the space in between is the suprapatellar extension from the knee joint. And that always has a small amount of fluid. So this is why on T1 and T2 you can see the small strip of fluid separating those two fat pads. So if we apply that knowledge to the plain film, you can see the fat pad here being translucent and the fat pad above the patella being translucent. So if you are wanting to say whether there is an effusion or not as a sign of synovitis, what you do is you look at the space in between, and that should be no more than 2 millimeters. If it's more, then you can identify with certainty that the patient has an effusion. And this is the case here, where you can see the anterior fat pad being loosened. Notice the large gap between that fat pad and the one above the patella, knowing that there's fluid, therefore, separating the two. And you can, of course, identify even much larger effusions than the one I've just shown you. Now, the process by far that causes a problem in joints is the rheumatoid disease process. And I've shown you a scintigram, not because in any way am I suggesting that this is what you need to make a diagnosis, far from it. But I'm going to show you this because it's quite nice to remind us that the process predominantly affects the wrists and the joints of the digits. It is universal involvement, and more importantly, it tends to be symmetrical involvement. And what you're seeing here is a combination of soft tissue and also the effects of that soft tissue on bone in terms of hyperemia and periarticular osteoporosis. But when you're interpreting hand radiographs, you need to be a bit more specific in what you look for. And the specific sign is, of course, on the plain radiograph, an erosion. The problem with erosions in rheumatoid disease is that it takes time for them to appear. So, for example, in repeated studies, it's been shown that about 30% have only 30% of X-ray evidence at 1 year, and the same patients, 60%, will have evidence of erosions at 2 years. So you need to know where to look. You need to be guided. So where are you going to look for erosions? Well, you're going to look at this area called the bare area, and the bare area particularly in the MCP joint, and more importantly in the proximal part of the MCP joint. This is what we're talking about. This is the MCP joint, and you'll notice on the radial aspect there's obvious erosive disease compared to the ulnar aspect, similarly here, and the bone is irregular because there is synovitis eroding bone. More specifically, the reason why you look at it on the proximal part of the joint is because there's a larger bare area in black here than on the distal part of the joint. So the synovium will hypertrophy and cause erosion at the site where there is no articular cartilage cover, which is why we call it a bare area. So have a look at this sequence. Just focus on that radiograph for a moment of that joint. A year later, you will see an erosion on the radial aspect of that metacarpal head. And then a few years later, the erosion is healing, but there's a tiny erosion developing in the base, again on the radial side of the proximal phalanx. And then with time, this is another patient, the digits that are predominantly involved are usually the second and third digit. Those are the two digits that tend to be involved particularly. And again, notice it's predominantly on the radial side on both the proximal and distal part of the joint. In the feet, similarly, you look at the metatarsophalangeal joint, but please remember that the capsule here inserts more proximally than it does in the metacarpophalangeal joint, so not surprisingly you can see erosive change which extends closer to the diaphyseal outline than the metacarpals. And you can identify bare areas everywhere. Basically, the bare area is a site where there's no articular cartilage covering, but is intra-articular, so not surprisingly, you can have erosions here, and at the junction of the head with the greater tuberosity, the capsule inserts somewhere at that point, producing a bare area here, which increases with time and disease, and then eventually it involves the articular surface and produces all sorts of problems to the subchondral bone. Similarly, notice joint universal loss, cartilage loss, and lots of erosive disease. Bone softening is also a problem. I have to say we don't see much of this these days because of the disease-modifying drugs that are being employed, but sometimes they do. We still see them in older patients. Basically, the bones become soft, and you have bilateral protrusio, acetably, and the same thing, by the way, happens in the shoulders. Rheumatoid arthritis of the cervical spine is more or less the same thing, by having erosive disease on the odontoid peg, as you can see on MR. And the peg can be completely destroyed, but apart from destruction of bone, because of the hyperemia, you also get ligamentous laxity, and this is quite important, because not so much because of your identification of it by noting the atlantodense interval increase, but very importantly, as I'll show you in a moment, but I'll start with the MR, the compromise to the cord at the back. So when you evaluate plain films, don't just look at the atlantodense interval. More importantly, look at the posterior atlantodense interval to find out how much room is left for the cord, because that is really what matters from the point of view of neurological risk. Less than 14 millimeters is a high risk. 10 millimeters, there's almost certainly always cord abnormality within that. Now we come to another fact which is important in basic knowledge is when you identify areas of synovitis, is there evidence of associated new bone formation? Rheumatoid disease doesn't cause new bone formation, but the seronegative arthropathies cause erosive disease and new bone formation. Particularly psoriasis is the disease that causes it. And this diagram shows you quite nicely what you're going to look for. You're going to look for erosive disease, which is fine, but at the edges where the capsule inserts into the bone, look for proliferative areas suggesting new bone formation. Here's such an example. Compare the distal and phalangeal joints here with the erosive disease, but notice there is new bone formation on both sides of the joint. And that, of course, tells you this is not rheumatoid disease, but a seronegative arthropathy. And you have to look carefully to make this interpretation, because you can easily suggest that these are subungual exostoses here, but they're in fact not. They're the proliferative phase of the reaction that takes place. And I'm going to show you this wonderful case. Please focus on just the thumbs. Forget what's happening everywhere else. Just focus on the thumb areas, the outline of the trapezium, the scaphoid, and the styloid process, and then lastly, the shape and size of the sesamoid bone. This is in 1985. Look what happens 5 years later. The sesamoid bone is much larger compared with the one on the other side, and there's now new bone formation along all the outlines of the bones that I've identified, whereas on the other side it is not involved. And then a few years after that, there's more new bone formation, and some new bone formation starts forming along the diaphyses of these digits. And then a few years later, the other sesamoid bone gets bigger, and you start having more new bone formation, the so-called dactylitis phase. And notice once again, not only is the sesamoid much larger, but there's now more new bone formation here, and the sesamoid gets bigger. And this is absolutely typical. This is what I meant by, please ask yourself, is there new bone formation of a psoriatic involvement? It is not just synovitis, but also starts to involve the adjacent ligamentous and tendinous attachment. Which brings us very nicely to the last topic, which is the enthesis. So we've said that the enthesis is the junction of the tendon and ligament as it inserts into bone. This is a very, very specialized structure, and by that we mean it's got definite histology, and what is important, that it contains fibrocartilage. So any disease that attacks fibrocartilage is likely to manifest itself at the ligament-bone junctions, or the so-called entheses. This is what we're talking about in diagrammatic form. There's your ligament or tendon or capsule, whatever you wish to call it, and these fibers merge slowly and imperceptibly with the adjacent cortex at the attachment point. And once you get inflammation, the inflammation involves the soft tissue component, the junction itself, and then slowly the bone actually going into the bone marrow as well. So how are you going to detect an enthesitis lesion? Well, it does help for us to know the sites where there is fibrocartilage. And then early on, the process of inflammation will cause destruction of bone. But very importantly, quite soon, and we're talking about weeks, at the latest 1 or 2 months, periosteal new bone formation or endosteal new bone formation starts being produced in response to the destruction. So I'm going to show you some easy examples. First, at the tendinous attachment of the hamstrings, at the adductors here, we've got clear-cut erosions with endosteal sclerosis in response in cases of ankylosing spondylitis. Somewhat more florid example here, very easily identified. And the same thing is happening in the spine. You've got the anterior portion of the annulus, which inserts directly into the vertebral bodies through Sharpie's fibers, as a classic fibrocartilaginous enthesis. And the inflammatory process causes first an erosion, which you can no longer see in this film, but then endosteal new bone formation, producing the so-called shiny corner side, in this case on both sides of the annulus itself. One thing about the erosion, it's got a specific name when it occurs in the spine. It's called the Romanus lesion. And then with time, you produce the shiny corner around that. But note that once the Syndesmophyte forms, which means that there is fusion and continuity along where the annulus was, the shiny corner slowly and slowly disappears. The Syndesmophyte, there are many types of syndesmophytes, but the one that I think I'd like to stress is the simple one, which is in ankylosing spondylitis, which was simply that what was once annulus here becomes ossified. And why is this important at this stage to mention this point? Because please remember that if you were to do an MRI on this patient, that annulus would appear low on T1 and low on T2, and that syndesmophyte will also appear low on T1 and low T2, and you would not know that this patient actually has a syndesmophyte. So this again highlights the weaknesses and strengths of all the modalities. The syndesmophytes produce the classic bamboo spine with fused sacroiliic joints, and it can involve virtually the whole of the spine as well. Another site where the enthesitis takes place, and initially it may sound a bit confusing, is inside a joint. And there's a reason for this. Some joints have a lot of fibrocartilage. And one of the joints that has a lot of fibrocartilage, and there is a reason for it because the ligaments anteriorly and posteriorly that support this very important joint actually extend intra-articularly and insert intra-articularly. So there's a lot of fibrocartilage inside the joint, and not surprisingly, you get erosive disease with sclerosis, as we discussed elsewhere. It is well known, and this is definitely the case by doing axial imaging, that the cartilage is thinner on the iliac side, so therefore you're more likely to start seeing erosive disease here, but more importantly, that the sclerosis also tends to be seen predominantly on the iliac side before the joint space is lost. If you have bilateral involvement, it tends to suggest ankylosing spondylitis. If you have unilateral involvement, which is confirmed by cross-sectional imaging, it tends to be predominantly the psoriatic arthritis. What can you see in the marrow in enthesitis? It's very simple. You can see marrow edema. And why? Because the enthesis inserts in a site where there isn't a very thick bone, meaning there is thick bone where it inserts, but it allows, because of the communication of the Sharpie's fibers close to the edge of the interface with endosteum, it allows, therefore, for the edematous process to go from the junction, from the enthesis, into the marrow space. So not surprisingly, you can see a lot of marrow edema close to the junction, and that's the clue on MR, that you have a junctional enthesitis. They tend to occur and spread along signs of mechanical stress, so you can get them at unusual sites. For example, the patella and the axial plane, you may think, are you sure this is an enthesitis? How does it occur? But if you look at the axial view, it's actually very simple. This is the point where the quadriceps expansion inserts, and also there are slivers from the patellar tendon, and there's a common insertion point in the front of the cortex, and you have erosive disease at the enthesitis and also a lot of marrow edema in the patella. And lastly, the same process, very importantly, occurs in the spine. Now, if you compare the T1 and the T2 image, you will see where the arrows are pointing to. They are pointing to areas of marrow change, which in this case is high T1 and high T2. And these are very important telltale signs that the patient has had a Romanus lesion, an inflammatory process, which is now healed. This is in the healing phase. But the important part is, of course, what's going on down here, because as opposed to these, this is more acute. It's inflamed in an early process. There's a lot of bone marrow edema on this vertebral body, and which you can see a bit more clearly on the T2 scan. When we follow this patient up, this will become very similar to what you see above, which is high T1 and high T2 in the healed phase. So I will conclude, therefore, that the emphasis of the basic knowledge has three main components. One, know your anatomy. Two, know what the anatomy looks like, knowing the strengths and limitations of the imaging modalities. But I think to really appreciate it properly, you really do need to know what the pathology is all about. And then, I hope, you as the beholder will see the beauty of everything. Thank you.